Hello and welcome to our new topic, one of the most important ones. Today, we will be discussing anticoagulants, a group of drugs that play a central role in preventing and treating thrombotic disorders. These drugs are among the most commonly used in clinical medicine, and their appropriate selection requires not only understanding their pharmacology but also the clinical context in which they are used. So, let's start. By the end of this session, you should be able to identify the drug targets of anticoagulants, classify these drugs based on their mechanism and route of administration, and understand their pharmacokinetics, adverse effects, and clinical uses. Most importantly, you should be able to apply this knowledge in selecting the right anticoagulant for a given patient. Hemostasis consists of three coordinated processes. Primary hemostasis involves platelet aggregation forming a platelet plug. Secondary hemostasis involves activation of coagulation factors leading to fibrin formation. Fibrinolysis acts as a parallel process to limit clot formation. Anticoagulant drugs specifically prevent secondary hemostasis. Thus, in the hemostatic cascade, there are three major points where we can therapeutically intervene. These correspond to three distinct strategies: inhibiting platelet function using antiplatelet drugs, inhibiting coagulation using anticoagulants, and dissolving an already formed clot using thrombolytic agents. The choice among these strategies depends primarily on the underlying pathophysiology of the thrombotic process. In arterial thrombosis, such as acute myocardial infarction, platelet activation and aggregation play the dominant role. Therefore, antiplatelet drugs form the cornerstone of therapy. In contrast, venous thrombosis, such as deep vein thrombosis, is primarily driven by activation of the coagulation cascade, or secondary hemostasis. In these situations, anticoagulants are more effective. Thrombolysis represents a parallel mechanism that actively breaks down fibrin and can be applied in both arterial and venous thrombosis, particularly in acute, life-threatening situations. In clinical practice, these therapies are often combined. For example, dual antiplatelet therapy with anticoagulation in selected high-risk patients, based on a careful assessment of both thrombotic and bleeding risks. This lecture will focus on anticoagulants, which primarily target the coagulation cascade of secondary hemostasis. Coagulation involves three major phases. First, formation of PAC or prothrombin activator complex. Second, PAC converts prothrombin into thrombin. And third, thrombin converts fibrinogen into fibrin that ultimately forms the meshwork of the clot. This diagram illustrates the coagulation cascade, highlighting intrinsic and extrinsic pathways converging into a final common pathway to form PAC, that converts soluble clotting factors in plasma into a reinforcement of the platelet plug. Note that many but not all clotting factors are plasma proteins in dormant forms which are enzymatically activated. Also note that platelets play a crucial supporting role here by providing a phospholipid surface that facilitates coagulation reactions. This is a classical example of positive feedback mechanism. While anticoagulants target this cascade, antiplatelet drugs act at the level of platelet activation. The parallel running fibrinolysis is not shown here. Anticoagulants can be classified based on their route of administration and mechanism of action. Parenteral agents include heparins and direct thrombin inhibitors, while oral agents include DOACs and warfarin. Mechanistically, drugs may act directly on clotting factors or indirectly by enhancing natural inhibitors or reducing factor synthesis. Parenteral anticoagulants include indirect thrombin inhibitors such as heparins, as well as direct thrombin inhibitors like hirudin analogs. Non-heparin agents such as fondaparinux and dinaparoid are particularly important in conditions like heparin-induced thrombocytopenia or HIT. This diagram highlights the sites of action of different anticoagulants within the coagulation cascade. Heparins act through antithrombin, while direct thrombin inhibitors act independently. DOACs target either thrombin or factor A directly, making them more predictable. Heparins act by enhancing the activity of antithrombin 3, leading to inhibition of thrombin and factor A. However, their effect can be variable due to protein binding, requiring monitoring with APTT. The most expected adverse effect is an increased risk of bleeding, which is universal for all anticoagulants. Protamine sulfate is an antidote that can be used to control such risk. A major complication is HIT, which paradoxically increases the risk of thrombosis despite low platelet counts. This is an immunologically produced adverse effect that occurs because heparin binds with platelet factor IV on the platelet surface and triggers immunoglobulin G synthesis against it. Fondaparinux and dinaparoid are non-heparin anticoagulants that primarily act through antithrombin to inhibit factor Xa. Fondaparinux is a synthetic pentasaccharide with highly predictable pharmacokinetics and minimal protein binding, which allows fixed dosing without routine monitoring. Dinaparoid, on the other hand, is a heparinoid composed of glycosaminoglycans and has minimal cross-reactivity with heparin-induced thrombocytopenia antibodies. Clinically, both agents are particularly useful in patients with HIT, where heparin must be avoided. Their role is therefore not just as alternatives, but as safer options in specific high-risk scenarios. This table summarizes the key differences among unfractionated heparin, low molecular weight heparins, fondaparinux, and dinaparoid. The most important distinction lies in predictability and monitoring requirements. Unfractionated heparin has variable effects due to protein binding and requires PTT monitoring, whereas low molecular weight heparins and fondaparinux offer more predictable anticoagulation. Clinically, this translates into a shift toward low molecular weight heparins and fondaparinux for routine use. In contrast, unfractionated heparin is reserved for situations requiring rapid control, such as in unstable patients or those with renal impairment. Take your time to explore. Loperidin is a recombinant hirudin analog that acts as a direct and essentially irreversible inhibitor of thrombin. Although it was historically used as an alternative anticoagulant in HIT, its clinical use has declined significantly due to its immunogenic potential, including the risk of antibody formation and anaphylaxis upon re-exposure. Additionally, its longer duration of action increases bleeding risk. As a result, newer agents such as bivalirudin and argatroban have largely replaced loperidin in modern practice. Bivalirudin is a synthetic direct thrombin inhibitor with reversible binding and a short half-life, making it highly controllable. It has a dual role in inhibiting thrombin and reducing platelet activation, which makes it particularly useful in percutaneous coronary interventions. Because of its short duration of action, its anticoagulant effect declines rapidly once the infusion is stopped, providing an additional safety advantage in procedures where bleeding risk must be tightly controlled. This table compares bivalirudin, argatroban, and loperidin. The key clinical distinction lies in their elimination pathways. Argatroban is hepatically cleared, making it the preferred agent in renal failure, while bivalirudin has partial renal clearance but remains manageable due to its short half-life. Loperidin, which is renally cleared and immunogenic, is now largely obsolete. Therefore, in practice, the choice between these agents is guided primarily by organ function and safety considerations. Argatroban is preferred in renal failure due to hepatic clearance, while bivalirudin is widely used in PCI due to its short half-life and controllability. Oral anticoagulants can be broadly divided into direct oral anticoagulants and indirect agents such as warfarin. Direct oral anticoagulants act directly on thrombin or factor Xa and provide rapid, predictable anticoagulation without the need for routine monitoring. In contrast, warfarin acts indirectly by inhibiting the synthesis of vitamin K-dependent clotting factors, resulting in a delayed onset of action and greater variability. Dabigatran is a direct thrombin inhibitor that acts independently of antithrombin and is administered as a prodrug. It provides rapid anticoagulation and does not require routine monitoring, but its high renal clearance necessitates caution in patients with renal impairment. It is also a substrate for P-glycoprotein, making it susceptible to drug interactions. Importantly, its anticoagulant effect can be reversed with idarucizumab, which is a major clinical advantage in cases of bleeding. Factor Xa inhibitors, including rivaroxaban, apixaban, and edoxaban, act directly on factor Xa and are collectively referred to as Zabins. These agents offer predictable pharmacokinetics, rapid onset, and fixed dosing without the need for monitoring. However, they differ in their dependence on renal clearance and metabolic pathways, which must be considered when selecting therapy for individual patients. This table provides a comprehensive comparison of direct oral anticoagulants, highlighting differences in bioavailability, dosing frequency, renal clearance, and bleeding risk. Clinically, apixaban is often preferred due to its lower bleeding risk, particularly in elderly patients, while rivaroxaban offers the convenience of once-daily dosing. Dabigatran, although effective, requires careful consideration of renal function and is associated with a higher risk of gastrointestinal side effects. Warfarin is a vitamin K antagonist that inhibits the synthesis of clotting factors 2, 7, 9, and 10. Unlike direct oral anticoagulants, it acts only in vivo and has no effect when added directly to blood in vitro. Its mechanism results in a delayed onset of action, as existing clotting factors in circulation must degrade before anticoagulation becomes effective. The effectiveness and safety of warfarin are significantly influenced by genetic polymorphisms in CYP2C9 and VKORC1. These variations affect drug metabolism and sensitivity, leading to interpatient variability in dosing requirements. This is a classic example of pharmacogenetics in clinical practice and explains why warfarin requires careful dose titration and monitoring. Warfarin has a delayed onset of action, typically taking several days to achieve therapeutic anticoagulation. Therefore, it is often initiated alongside a faster-acting agent such as LMWH or UFH, a strategy known as bridging. Once adequate anticoagulation is achieved, the heparin is discontinued, and warfarin is continued for long-term therapy. Warfarin is associated with multiple adverse effects, the most important being bleeding. It also crosses the placenta and can cause fetal abnormalities, making it contraindicated in pregnancy. Additionally, an initial hypercoagulable state may occur due to early depletion of protein C, a naturally occurring vitamin K-dependent anticoagulant, which provides a second reason and need for bridging therapy. Current clinical guidelines recommend DOACs as first-line therapy for most indications such as non-valvular atrial fibrillation and venous thromboembolism due to their predictability and ease of use. However, warfarin remains essential in specific conditions such as mechanical heart valves and antiphospholipid syndrome. Patient-specific factors such as renal function and drug interactions must guide therapy selection. In real-world practice, anticoagulant selection must consider specific clinical scenarios. For example, low molecular weight heparin is preferred in pregnancy, direct oral anticoagulants must be used cautiously in renal impairment, and warfarin must be avoided due to teratogenicity risk. Perioperative management also requires careful timing of drug discontinuation to balance bleeding and thrombosis risks. To summarize, direct oral anticoagulants are now the preferred agents in most clinical situations due to their predictability and ease of use. Unfractionated heparin remains important in unstable patients and those with renal failure, while low molecular weight heparin is preferred in pregnancy. Heparin must be avoided in HIT, and warfarin remains useful in selected cases but requires careful monitoring due to pharmacogenetic variability. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!